endometrial cancer. This is 2021 talk, very, very important, detecting endometrial cancer. Some interesting fact they have given and some clarity, because when we gave exam, half of the things were not clear. So I'm thankful that they are coming up with more and more talks which are useful to us. So let's start. What it says. Endometrial cancer. Why it is important? Because this is the fourth most common cancer in world, and this is the most common gynec cancer in UK. That's why it is important. Endometrial cancer is the most common cancer, most common gynec cancer in UK. So what is the most common gynec cancer in the world?
Cervical cancer?
Very good. Cervical, because of the more production and all that thing. What is the most common cancer in pregnancy?
Also cervical cancer.
Can anybody tell me why?
Reproductive age cancer.
Very good. Because the reproductive age, cervical cancer happen at early age, while the endometrial and vulval and all these cancer will happen at the late age. So by that time, women anyways will not become pregnant. So it's fair enough. Then, which is the most common cancer leading to death?
Ovarian cancer,
Very
Ovarian
good.
cancer.
Why?
because it is diagnosed late, so we usually diagnose it in an
Very
advanced
good.
stage.
Because it is diagnosed late, so
Info.
what can you do? So definitely the survival will be poor, more chances of death. So these are the things sometimes they ask you, which is the most common cancer, and this, that. All the things are important. Now, 90% of the women with endometrial cancer will present with postmenopausal bleeding. That's why postmenopausal bleeding is a significant thing to investigate. Can I ask you, a woman coming to you with postmenopausal bleeding, what is the chances of her having malignancy? How much is what you will tell to your patient? You have PMB, so I think you means the literature says that you have this much percentage chance of cancer. What you will tell?
Ma'am, usually 70-80% is because of atrophic vagina, this uterus, and it less than 10% or 10% is because of malignancies in PMB.
Very good. So it's only 10%. Maximum will be 10%. So anybody coming to you with PMB, you will tell them that you have only 10% chance of being cancer, but 10% is quite high, isn't it, for cancer? 90% it could be benign. More than 90% it could be benign, but that 10% is strong enough for us to evaluate her. So this you keep in mind. Though the cancer will present 90% of the time as postmenopausal bleeding, that is a different sentence. But if any women coming to you as postmenopausal bleeding, her chance of having malignancy is less than 10%. So please keep that in mind. Most common is atrophic and atrophy everywhere, atrophy in vagina, vulva, atrophic endometritis, and all that things. So please keep that in mind. This is given in 2015 TOG of abnormal bleeding or some heading. So that is there even in the material. So if you want, you can go through there. That's a beautiful talk, but that talk has lost importance because now this new talk has come. Survival rate, if you see, definitely the stage 1 is very good, 95% up till 95%. So it's a good survival if detected early. And the good thing is endometrial cancer get detected early because they present with bleeding. So any women coming with bleeding means having bleeding will come to the hospital to check. It's not hidden, at least like ovarian, it is hidden forever. So it's more revealing. So it's easy to diagnose. But nowadays they say that it is further increasing. 40% are dying. 40% women are now dying from EC, endometrial cancer, than they did earlier. So they are saying that it is now incidence is rising because of the obesity and all that. The incidence is rising and the death is also rising. So they want to give it more importance. So early diagnosis is important. You shouldn't miss the diagnosis. Age and obesity are the strongest risk factors. So please remember that sometime in SBA they give you which of the following is strongest risk factor. So age and obesity. Age, yes, because with age malignancy increase, and obesity specifically for endometrial cancer. What is the most common histological type? So it is endometrioid endometrial cancer. So please keep that in mind. We saw age obesity, other will be after menopause because there is no progesterone after menopause, only estrogen, which is formed by conversion from androgen. So that's why, because no progesterone, that's why in menopause it will be more common. Obesity, we already saw that 50% increase risk if additional 5 increase in BMI. 85% are diagnosed older than 55. So it's an old age disease, but with polycystic ovary, even it can be seen early. Lynch syndrome is a common, not a common thing, but Lynch syndrome is also important because there is a TOG on Lynch syndrome, which has only 4 or 5 points to remember. Just go through the tables of the TOG. So Lynch syndrome is an autosomal dominant inherited condition of DNA mismatch, which affect all these different kind of genes, out of which MSH2 is the most dangerous one. And then comes all this. So this gene, if that is there, you should remove everything by the age of 35 is what they recommend. But otherwise in Lynch syndrome, they say that if you remove everything by 40 years of age, it is cost effective. So that line also they have asked in exam. By what age the removal of uterus and ovary in patient with Lynch syndrome is cost effective? So it's by 40. So you should remember Lynch syndrome salient feature because that's also a favorite of exam. So these are the risks: increased age, obesity, DM, diabetes, hypertension, PCOD, early menarche and late menopause, nullipass. If they become pregnant and they get children and all that things, breastfeeding and all, that is decreasing the risk. So this is how you keep in mind, because the same way it happens for ovarian cancer also. Parity is going to reduce the risk. Parity is a protection. So this you should keep in mind. Oral contraceptive and parity is a protection both for endometrial and ovarian cancer. So these all we saw that Lynch syndrome is a risk. Physical inactivity will lead to obesity, dietary factor, tamoxifen therapy. These are the risks for cancer. And the protective will be losing weight, bariatric surgery, physical activity, parity OCs, breastfeeding. Smoking is something which is always we see smoking as a risk factor, but it is protective here because smoking will decrease the vascularity to the endometrium. So in a way, it is a protection for endometrial cancer. So this was something I really found very unusual, but I could think of the reason. So this is what I think the reason is. So anytime they come with postmenopausal bleeding, the causes could be many, out of which it could be endometrial hyperplasia, polyp, atrophy, endometritis, anything. So benign things also has to be ruled out, as more than 90% are benign only. For endometrial hyperplasia GTG, I'm not covering that today because that is also covered in YouTube already. It's covered in an extensive way. So it's a very important guideline, and there is always a question from this. So please go through that record. Because everything is not practically possible to be covered in the session, then you cannot remember all the important thing in one go. So small reading at a time will be more useful. Nowadays, because we are not doing cytology, because earlier when they were doing pap smear in the first go, sometimes they will see abnormal endometrial cells and endometrial cancer will be diagnosed early. But now because it is HR-HPV testing, so you cannot diagnose. This benefit of pap smear has gone. Then the referral, again, it will be 2-week wait. 2-week wait for the women who are more than equal to 55 with PMB, or for women less than 55 with PMB, or they will do the ultrasound directly for the women who are more than equal to 55 with unexplained vaginal discharge and hematuria. So this is how the referral pathway for the women with postmenopausal bleeding. So probability of endometrial cancer in a woman with postmenopausal bleeding from less than 1% in women in under 50 to it will become 24% for 80 years. So with age it is significantly increasing. Less than 50 only 1%, for 80 year it is 24%, so quite high. If persistent unscheduled bleeding for more than 6 months after HRT, you are going to evaluate it. This we already saw with HRT. New onset PMB should only be referred if the bleeding continues more than 6 weeks after stopping HRT. This is what the recent recall, that you have got abnormal bleeding with HRT, you have stopped the HRT. So how long you should wait? So 6 weeks. If bleeding continue beyond 6 weeks after stopping, again you have to refer her. In premenopausal women, intermenstrual bleeding is a better predictor rather than heavy bleeding for endometrial cancer. So what you will do? How you will diagnose endometrial cancer? We don't know, right? Any women coming to you with postmenopausal bleeding, what will be your first step? Can anybody tell me that?
TVS?
Very
TVS
good.
for endometrial thickness.
TVS, this is what we do, isn't it? Yes, TVS, because TVS will tell you about endometrial thickness and accordingly you will triage the women. Where to send her? Is it a high risk? Is it a low risk? Shall you will send her home or what you will do? So TVS is a first tool and it's the triaging tool. So TVS is the first line investigation and then you can send her to one-stop postmenopausal clinic also where everything is done in one go. They'll get scanned, they will get reviewed, they will get treatment also in the same visit. So there is some one-stop postmenopausal bleeding clinic where they can be referred. Now, TVS is a good thing. It will tell you what, how, where. If TVS, it will show the thickness as well as the character of endometrium. If the endometrium is not looking regular, it is looking like eaten out, moth in appearance, irregular looking endometrium. So you will be suspicious. And if it is a regular endometrium, you are fine. So it's not thickness, but the character of endometrium also is important when you do the TVS. And then the color Doppler definitely can help you sometimes in distinguishing malignant from non-malignant. And thickness is always what you look for. So what you should remember, if you find a woman with postmenopausal bleeding, you are going to do TVS and you will do the thickness, you will look for character and refer them. Accordingly, you will do the treatment. If you find an incidental finding, what to do? They will give you in question that you are doing scan for something and you found an incidental finding of thickness, thickened endometrium. So what you will do? So they say that it's not very clear cut, but if the more than 11 mm, the chance of cancer is high. So that's why if they'll give you more than equal to 11 mm, you're going to investigate further. Means you will take the biopsy. So any women with thickened endometrium or any women with incidental finding of more than 11 or 11, you are going to take a biopsy. How you'll take a biopsy? She came to you, you did TVS, you found thick endometrium more than 4 mm. You want to do biopsy. How?
Pipple
People.
biopsy.
People. Very good. So to start with, you want to do the least invasive. So you will do the people biopsy. So when you will do hysteroscopy guided biopsy.
If pipple biopsy is inconclusive, or
Very
the
good.
sample is inadequate, or
Yes,
there
very
is
good.
intermenstrual bleeding with along with uh, uh, if if there is structural abnormality in the uterus like a polyp.
Yes, very good. And
And one more, ma'am, if the bleeding, if with the biopsy says is normal, but the bleeding is persisting, then we will do the this supervised biopsy.
yes, means sometimes discrepancy, like people will be showing, means she's coming with persistent bleeding. Persistent bleeding is also a very important finding that you have given her treatment. Like people showed low risk, you have given her treatment for whatsoever, and then still she's presenting with the same complaint. So then in that case, whenever you are in doubt, you will be your next step will be hysteroscopy biopsy. Whenever it is a persistent bleeding in spite of treatment, people hysteroscopy biopsy. So whenever there is a doubt in your mind, you are going to do the hysteroscopy for women. So if there is persistent symptom or suspicious finding, if there is thickened irregular endometrium or other concerning feature, if recurrent prolonged bleeding, or if endometrial sampling is non-diagnostic in people, you are going to do the hysteroscopy. MRI sometimes you will do only in cases of pre-staging of endometrial cancer, so you will never choose an MRI for postmenopausal bleeding. Only when you are suspecting endometrial cancer, you can do MRI to see the invasion in the uterus, because less than 50% and more than 50% change the stage. But sometimes, rarely, for detailed description of the endometrium, sometimes you might be needing it, but that rare thing maybe, if you forget, that's fine. Don't mistake it with MRI will not be very useful tool in PMB. Only rare of the rarity. So what you will do, 2-week referral you have done for PMB, they did the TVS. If it is less than 4, they are happy. Nothing to be done, send her home. If she's more than equal to 4 and not irregular, you will simply do the biopsy, which is pupil biopsy. If it is inadequate, if she is high risk for endometrial cancer, you are going to do the hysteroscopy. If low risk, you can again discharge her. If biopsy is normal and a symptom persists, again you will be doing outpatient. Or if it is irregular polyp, more thickness with irregularity and polyp, you are worried, so you are going to do directly hysteroscopy biopsy. So these are the indication we already discussed, but you have to remember this part, that if it is more than equal to 4, not irregular, no polyp, no other high risk, nothing, then you can simply do the pupil biopsy. So why you are screening? Basically, you are screening because sometimes you can find endometrial hyperplasia, sometimes even you can find endometrial cancer in asymptomatic women also. So screening is required to detect the asymptomatic women, because now we saw that the incidence of death because of endometrial cancer is increasing, means the diagnosis is getting missed because all the women are not presenting with symptoms. So in asymptomatic women you can screen, but screening usually is not recommended routinely for endometrial and ovarian cancer, because screening, there is no screening modality which is 100% fitting into the screening category. But they say, but at least for high risk you should do, like Lynch syndrome, where you know that risk is quite high, 15 to 60% risk in Lynch syndrome. So it's quite high, up till 60% means quite high. So they say that in cases of Lynch syndrome, you can do the screening, which will be annual TVS, hysteroscopy biopsy. So don't think it is PIPL. It's hysteroscopy biopsy and annual TVS for Lynch syndrome women after the age of 35, because for MSH2, you have to remove the uterus and tube and ovary, everything at 35. So beyond that, you are going to screen annually with TVS and hysteroscopy biopsy. Please remember this well, because this is an important exam question. So screening only recommended for high risk group. Otherwise, no. So these are some novel tools they have mentioned in the talk, like uh, menstrual blood, and they say that endometrial lavage, brushing, cervical brush, vaginal tampon, vaginal swab, urine sample, blood sample, all these are under investigation still. Nothing is documented. But they have come up with all these tests which are non-invasive, because ultimately pupil biopsy or hysteroscopy biopsy is invasive. So you want something unpleasant, non-invasive, means pleasant and non-invasive. So that's why you have come up with all this novel technique, but still it is in trial phase. This is from the old talk, which I mentioned, 2015 talk. What are the reason for postmenopausal bleeding? If you see, cancer is only 10%. And the most common is atrophic endometritis and vaginitis, which is 60 to 80%. And second most common is exogenous estrogen, means HRT. You give exogenous estrogen. And then the polyp and hyperplasia. Now, type 1 and type 2 cancer. So nowadays they say that type 2 is increasing, which is in the postmenopausal women, high grade tumor, serous and clear cell tumor, very aggressive, and P53 mutation. So these are bad tumors. type 2 tumor, which is seen in postmenopausal. While type 1 tumor, which is a good tumor, which is seen in postmenopausal women, and it is because of the estrogen. This is not because of estrogen, this is because of P53 mutation. This type 1 is because of estrogen. Peri and postmenopausal, usually it will be like hyperplasia followed by cancer. So it is the most common one, endometrioid. Tumor grade will be low grade. So it's a good one. And this is also more common one also. But nowadays they are saying that this is also rising. That's why you're not able to detect things. So they may ask you about type 1, type 2 tumor of endometrial cancer, which you should be able to remember and differentiate.